The guest in my virtual chair today was Dr. Stephen Ponder. Dr. Ponder is the author of the book Sugar Surfing. If you're diabetic or you know anybody or love anybody who's diabetic, you're going to want to watch this. Dr. Ponder is an endocrinologist who specializes in type 1 diabetes for pediatrics. But the key thing here is that he's a diabetic. Dr. Ponder was diagnosed in 1966, and we're going to talk to the man behind the book. All about what it was like to have diabetes in 1966, all the changes in technology that he's seen that makes such a difference for us, but more importantly, being a diabetic and having a conversation with a doctor who specializes in it, who is diabetic, it's like a conversation I've never had with anybody. I think you're really going to enjoy it, and you'll probably learn a thing or two. And if nothing else, the shame he takes away in the numbers game, please watch. It's just so good.
Hey, baby, it's time for the Nikki Alpert Podcast. Come on, pull up a chair. We gonna have some fun.
Hello, Dr. Ponder.
Hello, Nikki.
It is so nice to meet you. I can't stand it. I wish it was in person, and I'm so sorry that it's not.
I wish I could be there.
So do I. So, Diabuddies, we are talking to Dr. Ponder, who so many of you know as the author of Sugar Surfing. And that is certainly how I found him, because he lives in Texas and I don't. And also, I'm a little old to be one of your patients, I think.
Maybe. I don't know. I've been seeing some older people lately. They've opened up some of the rules since pandemic hit.
Oh, that's interesting. I didn't even know there was rules that if you were pediatric, maybe you couldn't treat other people or other grown-ups, people after.
One of the things that's changed is they've allowed us to do more telemedicine, even outside of state lines. Now it's limited, and it is largely limited to younger people. But I have every now and then some adults that have asked questions, and I do my best to help them.
Well, yeah, and since you have it, it's great. Since you have the disease, talking to a doctor who has it, I can't even imagine. But let's start at the beginning, because we could all be talking about sugar surfing, and there's so much out there with Dr. Ponder talking about his book and answering questions about his book. And so this is not the place for that today. I wanted to talk to the man behind the book. I want to talk to Dr. Ponder as a diabetic, two diabetics having a conversation, but very often, and I'm sure many of you guys feel this way, that when you're talking to your doctor who doesn't have diabetes, I think sometimes we feel like we know more about the disease than they do. But to talk to you, Dr. Ponder, and have you know all that you all that you were taught in school and all that you know, just makes this so much more interesting to me.
I understand that completely, and I even use that example when I'm speaking with families. I'll tell them that I've had diabetes for now 55 years. And leading up to that, I'd say I've learned a whole lot of things through my life. But I'll be the first person to tell you I don't know everything. I don't know you. I don't know your child, your family. I don't know your unique circumstances, which makes you the expert of you, even though I may know me quite well. So I never try to put myself in a position of what I would call superiority over anyone. I certainly understand the disease. I've certainly traveled my own road with it.
Yeah.
But I make a point to illustrate to them that they are the experts of their lives.
I think that might have been the best advice I was given when I was diagnosed. So I don't know how old you are. I've heard you say over the years that you were diagnosed, or you've been a diabetic for over 50 years. So how old were you when you were diagnosed?
I was diagnosed at 9.5, and I'm 64 years old now. So that's where
there's the 55.
55, yes.
So I'm 36 years in. I was 18, which is a whole different thing than being a real kid, I think. But I remember Dr. Sherman Holvey was my doctor. And you may know that name because he was the head of the ADA at some point.
Right.
And two things that Sherman told me that stick with me all the time. Number one, I will help you, but you must be your own doctor. You live with this. You've got to know this better than I do, and you're going to have to make decisions about it all day long without my help. So you must take care of you first and use me as a sounding board. I think that was great advice, right?
Absolutely. The average person makes 35,000 choices a day. I point
I
that out
love this
too.
thing that you do. Please go on.
It's basically quite easy for anyone to Google up that the average person makes 35,000 somewhat conscious choices every day. And when you think about that, that's an enormous amount of decision making that we just casually do in some ways, day in and day out. And just add diabetes to that mix. I'm not sure that it adds more thousands of choices. I think it substitutes maybe some choices for others, but they're still choices. And
There's
that's
more.
what drives care. It's the choices that drive our care.
Yeah, and there are more choices. And then if you're like me and you have ADHD, it gets really difficult. So the second part of the advice that Sherm gave me was that the most predictable thing about diabetes is its unpredictability.
Absolutely. It's nothing ever happens the same from day to day. As I metaphorize that in sugar surfing, saying the only person with a straight line blood sugar is a dead person.
A dead person.
Which means that every day is literally different. You can't line up 288 blood sugars in a row and expect them to ever be exactly the same sequence from one day to the next. And most people will nod their heads and say, yeah, I get that. They can be similar, but they will never be precisely the same.
I do remember my doctor is Mitch, and I remember going to Mitch and saying, I just want my line to be straight. And he said to me, Nikki, you're going to have to die for that to happen. It wouldn't happen on me. It's not going to happen on you.
I'm glad we give consistent advice as a profession. That's good.
Well, I don't think everybody does, but it's interesting because, I talk to lots of diabetics, and I have friends who say, oh my God, if you're diabetic and you're having trouble, call my friend Nikki. Because like the way I feel with you, they want to talk to somebody who has the disease also. So I get to talk to a lot of people. And I don't find, even with the same info from the doctors being given, the same kind of advice, if you will, I don't find that, we all know that not everybody hears advice the same way. And with the levels of interest in taking care of themselves, sometimes that advice just doesn't do anything.
I try to get my families who ask for that kind of help connected to the right people within my own practice, or even if necessary, adults that I used to take care of as adolescents who would be willing to reach out and speak with them. Of course, with HIPAA laws and so on, I have to be cautious about that and I have to ask for permission. But more times than not, that's not an issue for one of my older patients that have graduated from my practice to speak to one of the younger ones, or even a peer, another family member, another family who wants to talk to another family who's
a
just
mom or a
diagnosed.
dad or something like that.
Exactly.
By the way, you can put me on all those lists if you want someone else to talk to. If after today you feel like I might be good for that, please put me on that list.
Absolutely, certainly will.
Okay, so let's backtrack for a second. So many of you know that Dr. Ponder always has his silly fun hats. And I don't mean silly, but fun, silly. They're silly. So there's the shark. And when I first started seeing you in your hats, I noticed at first, I thought they were all ocean themed. So I thought, oh, maybe this started when he wrote Sugar Surfing. But then I saw you the other day wearing a Corona hat, and I kind of wanted to see how many hats we could get in today. So there's this, he says this is the girls like this hat best. So this is the unicorn hat. So whenever you get the vibe to change hats, let's see, because he has over 100 of them. So let's see how many we can get on today.
I have a few selected out for today's talk, for sure.
Great. Okay, so let's go back again. So you're 9.5, you get diagnosed. How was that?
My diagnosis was not explosive. It wasn't diabetic ketoacidosis related. I had the slow weight loss, the increased thirst, the increased urination, and so on. Parents noticed that I was getting up at night to go to the bathroom. They took me to my physician, a pediatrician, who fortunately had trained in the same school that I would eventually go to in Galveston, and he had a good handle on the signs and symptoms. They made the diagnosis. The difference in 1966 from today is I spent 10 days in the hospital when in today's world, I would probably spend
3 days?
an afternoon in a clinic getting taught as an outpatient. But 10 days I never had an IV. I basically sat in an old style children's ward with 4 other beds, 2 on either side of me. And I was there for 10 whole days. It was
to learn everything.
Yeah, to learn. Well, they handed me the classic orange, and they handed me in fact, I did bring one prop. I have a whole bunch of these things. This is this is 55 years old, approximately. It's an old plastic disposable insulin syringe, and I have a whole case of them. I saved them.
Wow.
And I pull it out. This is just an original. This was if I can show that.
How long is that needle?
I'm going to take the cap off. It's 3/4 of an inch long.
What's the gauge though? I mean, boy, those have gotten thinner.
I'll be precise for you. It's 26.5 gauge needle.
And I use a 36 now, so mine is way thinner.
Yes, and then this was actually how we did it in the hospital. But when we went home, we purchased glass barreled syringes.
And it had to be boiled?
With reusable metal needles, which also had to be boiled. So my parents would do that every morning and then prepare the injection and give me the shot. Now I had one injection per day because that's what the time called for. We had an insulin called Lente, Lente.
I think I might have started with that I may have. Yeah.
It went away a few decades ago, but it was equivalent to NPH insulin.
Right, a long acting all day.
It was what
or
we
basal
long
is what they call that now, right?
Yeah, exactly.
Okay.
And I took one injection of that a day. That was it. And that was what I did for, quite frankly, for 15 years. That was it. One shot a day.
So it didn't suck so bad.
The only problem was you made reference to the size of the syringe and the glass barrels. It was interesting. Those glass barrels, the plungers would sometimes freeze or lock in the syringe cartridge, and you get a half the injection and it would freeze, and nothing you could do could dislodge it. So you had to withdraw it. You had to hit it with your finger and loosen it up and take another shot with one of those big, thick needles. Now, remember, these were reusable needles that were 20.
So they were dull after how many uses?
And nobody taught us how to sharpen them.
Oh, and how long did you use it for?
2 to 3 weeks. Yeah.
What kind of bruises did you have all over yourself?
Now, I had probably more of, over time, atrophy. You've heard of lipohypertrophy or buildup of the tissue. Back in the day, because of the impurities in the insulin, you would tend to have loss of tissue. And so on my thighs and in the back of my hip, I'd have some depressions in my skin. Now, those have filled in over the years, but for many years, that was what I had. And quite honestly, my father would give me my shots in the morning. So I just roll over and I get it into my hip. So I had a lot of tissue in there. And so if I had bruises, he never told me I had, and I never looked, quite honestly.
Because you weren't a girl.
Exactly. I wasn't thinking about that, but I probably should have. But I just was wanting it to get over. I'd roll over and say, give me this shot. I'd think about something else. He'd do it as quickly as he could. Now, my mom didn't do as good a job because my mom was always fearful of hurting me. Yeah. And so whenever she put the injection in, the needle in, she pushed the needle in slowly, which is a classic mistake people make when putting a needle in. And of course, you and I both know that's kind of painful, right?
Yeah.
And so I learned to not enjoy when my mom had to give the shot, and I would really dread that. But I mean, she did it, and I love my mom, and she did great on all the other aspects of my diabetes. But that was tough. That was the tough part. Now, granted, I wasn't doing that 10 times a day. Right. I did it once a day.
Like we do now.
Exactly. And looking back, it was just, that was my exposure to diabetes. We checked urine tests.
Yep.
I have images of that in the book, my mom's logbook, and we would get urine samples and use the old Clina test where you put a few drops and a tablet in there and you get color changes. And that's how we measured our diabetes. One thing I always like to tell people is that you grow up using colors as a way of expressing diabetes control. You're not confined to numbers, and numbers aren't used to grade you. We had no A1C until the early 1980s, late 1970s. And so I didn't grow up with the handicap.
Shame.
Yeah, the numbers game. I didn't have a numbers game. It was just all colors. Now, blue was what you meant. Blue in a urine test meant no sugar in the urine. Right. It also meant the blood sugar is about under 180 on average. That doesn't
imagine that being a good place now with all that we know.
Exactly. And so I like blue as a color. Orange, bright orange meant you had
not so much.
It wasn't my favorite color.
Yeah.
Orange never turned out to be a
so
color.
Was your mom, you know, in my family, I was diagnosed at 18. And classic like you, I lost 20 pounds in a week. I was starving. I was thirsty. I was passing out left and right. It was like 2 weeks. And I remember bringing a bowl of water to bed with me and a straw. And I couldn't get enough water in my mouth. And I picked up the bowl and it spilled all over me. And I screamed on top of my lungs. And my father came running into my room. And there I was like a drowned rat. And he was like, what the hell? And I think at that point I was about 84 pounds. I went to a doctor the next day. There was sugar in my urine. He sent me to Sherm-Holtby. And I also spent 2 weeks in the hospital and I got the classic orange treatment and a nurse was diabetic. I learned everything. But interestingly, because I was going to ask you about your mom and your dad. So did your mom take it harder that you were diabetic? Was it harder for her to deal with?
I wrote about this in the book, I think, but I'm adopted. And
Okay, so it
so
didn't come from them.
there was no way they could say it came from them.
Right.
And so if they did harbor those feelings, they never expressed them to me. What they did do, and what I'm forever grateful for them for doing, is for taking responsibility and never giving me a doom and gloom
Attitude.
concept. I never thought this was the end of my life, although I learned that later in what I learned about the longevity of people with diabetes in 1966. And it was, you would be lucky to live 40 years, 30 years. Now, nobody ever told me that. That's
Good.
what I kind of learned through research. And so that framed my thinking for many years to come until I reached those ages. And then I was still relatively healthy and doing well.
Like, it's been 40 years. How much time have I got left? I wonder.
Yeah, exactly. So my parents were very positive about all of this. They never thought there was something the matter with me. They let me do things I wanted to do. Keep in mind, we didn't have all the instructions and all the structure around diabetes we have now, which I know feels like it boxes patients as well as families in quite a bit.
Well, the difference in the 20-ish years, it was 18 years since, because I was born when the year you got it. So 18 years later, there was a big difference. I was taking 2 different kinds of insulin. I was taking rapid acting and long acting. I was taking 4 shots a day. There was no such thing as micro dosing back then. They didn't want you to do any of that stuff. So in just 20 years, it changed so much. And so the difference in how you were raised with it and how I was raised with it in that short time is so different. But again, much like your parents, but I was older, so my parents weren't so involved. I was almost a grown up. And so my parents were like, this is on you. But I know that my father took it to the grave, the guilt, that he was just wished it was him instead of me. And my mother was like, if anybody can handle this in our family, it's you. And so you got it because you can handle this and you're going to rock it and you're going to be fine. And then there was my dad who was sniffling in the corner. They weren't even married, but my mom threatened to kick his ass if he didn't stop crying in front of her daughter. Right. And he took that to his grave. And I wonder if it's one thing for you to have a newly diagnosed patient who's a kid and you're dealing with the kid, but then you've got the sniveling parents in there sometimes, I'm sure, don't you?
Oh, let me tell you, what you're hitting on right now is exactly something I learned through observation and from listening all the years I've been at diabetes camp, which is almost 40, to kids around the campfire. The very first thing I tell a newly diagnosed family or a person with diabetes is that they did nothing to cause this, that type 1 diabetes is its own thing. There's no room for guilt. And the first thing we have to get rid of is the guilt monster. And if I'll do this and I'll see
in the
moms
whole
and dads.
Family.
Oh yeah, the whole family. And,
Yeah.
and their shoulders will drop. And they'll even say, they'll exhale, take a deep sigh of relief and say, I'm glad you told me that because I thought I did something wrong. I thought I should have done something which I didn't do. I thought my child did something wrong. And it just totally changes the atmosphere almost instantly for a lot of families. Now, it's not always apparent with some, but I still, with everyone, that's my signature first thing I tell people is that you did nothing, absolutely nothing to cause this. And I hope everyone else that hears this has heard something similar, or and I hear any physicians that hear this, I hope they adopt that. I think most of them do. I'd like to think that those of us in this field share what we know with each other and have had similar observations, but dispelling the myth of causality on the family is so important with type 1 diabetes.
I think it probably works very well widespread in your specialty area, but I wonder how often doctors who talk to grownups remember to take care of their mental health that this attacks. I don't think they're very good at that sometimes.
I think there's so much speed and so many things to discuss. And sometimes not all of us physicians are really adept at some of the emotional aspects of a disease. And it makes that difficult to discuss. And one other group we didn't even mention, of course, are other immediate family members like siblings. Quite often siblings will harbor a lot of resentment and or guilt about the disease, or that they may get it next. And so there's a lot of that going on in the background as well.
Yeah, I have a friend who has twins and the son has it and the daughter doesn't. And the daughter feels guilty that she's healthy. And she's also jealous of the attention he gets. Oh, it's hat change time. What are we putting on now? Oh, Dory, right?
Yeah, Nemo.
Nemo, sorry. My kids are 21. I was not really, I've gotten lost in all of that. That was fun. Thank you for changing hats. I would have forgotten to ask you too. I think that, like you said, the siblings, sometimes they feel left out because one's getting more attention and treated a little extra and soft. And so I'm sure that exists everywhere. So you're 9 years old, you get diabetes. It's not miserable, but it's okay. And your parents are supportive. How much later did you think, oh, I'm going to med school?
That happened in my teenage years. It wasn't something I don't think that I was thinking about. I was just a normal kid. I just did normal kid things. I played outside. We didn't have the internet.
Yeah.
We had 3 television channels. I had friends. I got involved with all sorts of hobbies and interests, ham radio, chess club. I was kind of a nerd. I played tennis. I was in the band. I had a normal life.
What'd you play in the band?
I played alto and a baritone saxophone.
Oh, my daughter plays the bassoon, so I'm very familiar with all of those.
I sat right next to the bassoon
Sure
player in the band. But those were things that I just lived a normal life. And it's also one of the things I tell people at diagnosis is my goal for your child or your son or daughter is not an A1C. It's not a time and range. It's that they can live what they consider a normal life. And
right.
I was blessed to have 2 parents that allowed me to live a normal life, a family that allowed me to live a normal life. I have a sister as well. And those things are you can't measure the value of that. Yes, I happen to have diabetes, but it wasn't really what I like to think defined me.
Right.
I lived with it. I learned eventually how to manage it. When I was a child, I didn't manage it at all. I manage it now, not in the least, but I managed to get through that. And when I have families come in and fret quite a bit about what their kids' blood sugars are, say 150 or 200, and they're worried about that, I have to kind of I have to grin and step back and say, I spent 15 years, my whole childhood.
Not even knowing.
Probably 200 or higher, yet I'm still here 55 years later. So don't think that just an incident of high or low blood sugar is the end of life as you know it.
Did you suffer complications from years of that at all?
The first thing I got when I went into medical school in 1981, I first saw an ophthalmologist, believe it or not, and they found some background retinopathy in my right eye, which scared me. Obviously, as medical school, I was learning, okay, I'm going to go blind now. This is all the stuff I'd heard before. I had some prophylactic laser burns up here in the right temporal area. And over the years, of course, my control improved. I went on a pump in 1981 and everything else that's come since then. And the last several eye checks I've had, the last decade, 2 or 3 decades, have been, oh, your eyes look normal. We can't tell you have diabetes anymore. And so a lot of that stuff I'd been taught about the irreversibility of some of these early changes was just that. They were wrong, and they were reversible. And so that was the first thing I had. I think as I've gotten older, of course, I'm 64. I'm entitled to have a cardiovascular disease like anybody else. And so I had a little bit of that. And when I turned 50, had a small angioplasty, no stent or anything done, and that could have easily been from something else. But I could call it diabetes if I want to, and I'm not going to run away from it. Or not. Yeah. And so and my cholesterols and lipids were not that far off. And so, but I'm on a statin. My blood pressure is well controlled. I had some microalbuminuria, small protein leakage in 1981 also. And that's 40 years ago and still the same as it was then. Right. So that's been locked down through use of ACE inhibitors and improved control. So I don't think that, ideal control guarantees anything.
Right.
It just it buys you a ticket to the lottery of life and you can continue playing. And that's kind of how I look at it. And you still have to take care of yourself day in and day out and try to avoid other hazards, immediate and long-term, the best you can.
But don't not do stuff because you're diabetic.
Oh, absolutely.
I think I'm not certain how much of that comes from nature and how much of that comes from nurture, because like I told you, I had parents who were on opposite sides of the spectrum of all that. My dad was just so sad about it for 30 something years. And my mother was like, of course she can, of course she will, of course she does. And I remember being in the hospital and somebody saying, but why you? And I remember saying, well, why not me? Who does somebody deserve it? And that was just an innate feeling I had about it. And then I have the people who say to me, but you look so healthy and you're so happy. How can you be so happy if you're diabetic? And, what can't you do? And I honestly feel like, yes, I was raised by both of these parents with an enormous amount of love and lucky. But I also think that some of it, you can tell people how you live and what you think would be their best way of living till you're blue in the face. And some people just like, I can't, I won't, I don't, I'm miserable, I hate it, right? Don't you have
Right.
those people
Yes.
too?
Yes, this condition, you and I both know, is largely, sometimes it seems almost exclusively driven by one's state of mental health.
I think so.
And if you come into it with a lot of baggage, or at onset you're given a lot of baggage that I mentioned earlier, I try
Yeah.
to alleviate, then it will weigh you down. Plus, there is a higher tendency for people with chronic illnesses of every type, whether it's diabetes, asthma, or you name it, to have some mental health burdens. And now, of course, we're living through one of the greatest mental health burdens on the planet in the last century, which is this pandemic.
Yeah.
That's also weighing heavily on people too, not just those with diabetes. So yeah,
Right.
mental health and psychology. And I've known to say in my talks to medical students and residents that 90% of managing diabetes is psychological. 10% of it's all the stuff, the insulin, the pumps, the sensors. Those are just devices, but how you live with it each day, the attitude you wake up with in the morning.
It's a decision you make.
Yes, I look at it this way. I have been given a second lease on life that began on March 1st, 1966. In the natural order of the world, I
That's
should have
right. You
died
would have
55
died.
years.
That's
yeah,
right.
And sad to say, there are people, even right now, as you and I speak, on the planet who live in parts of the world who don't have access to even anything remotely like what you and I did, even back at our diagnosis, who do die from this disease. So
Yeah.
we are blessed and fortunate to live where we live, to have had the contact with the people we've had contact with, and to be able to learn what we've learned. So
Yeah.
I don't take any of that for granted. I appreciate it every single day of my life, and I will till the day I die.
I am so with you on that. As so many things you've said have made the hair on my arm stand up, but I know that with all these lights to make me look younger, you can't see the hair on my arms. So speaking of the pandemic, was it scary for you to go back to work, or was it not, because everybody there is care? Like, what do you tell people now? I'm sure the parents are freaked out about their kids going back to school and getting it. Are you more cautious than like, I haven't left the house. I mean, I've left the house, but it's like, I've not gone back to work since March 7th. Obviously you're not doing that, but how much of your practice right now is all talking about that? And what's your advice to people like us?
Well, we practice masking and distancing and hand washing, all the things that I think we all should be doing, and I promote that every chance I get. And I live in not as an endemic area as you live in. You're in California. I'm in Central Texas.
And so glad you're not near El Paso right now.
Yes. And so where we're located, it's a little bit less, the case rates are a little bit lower. Still, they're out there, and we have them at our hospitals. So we are very meticulous about who comes into the building. For about a month, we did nothing but video conferencing, telemedicine, like what we're doing right now with patients, and we still do from time to time. But people are temperature checked, symptom checked, and such. So we're taking every step to mitigate that and still be able to come to work and help people. And with that being done, we've had extremely good show rates. We've not had any significant reduction in the flow of our patients, at least through our profession here at Pediatric Endocrinology, which is good. I'm very fortunate for that.
Yeah. And have any of your kids gotten it?
Yes, we've had several kids that have gotten it. In fact, of course, I can't tell you exactly details, but we've had a recent patient who was diagnosed with it at the time of their diabetes diagnosis in DKA. Now, not really sure it triggered anything. It was by the way, this 10-year-old child is also COVID positive as well. And we have other patients with other endocrine conditions that have been tested positive. Now, I have patients that are established that have gotten it, and some of the older kids have gotten fairly sick with it. We've not lost anybody, fortunately, to it. Their parents who fall ill, oftentimes, as you might imagine, do get fairly symptomatic. Some of them do get sick. Whereas others will be very, very minimally to not even symptomatic at all. So just like what you've seen in the media, there's a huge range of individuals who get this now. And we don't know what the driving forces behind that are, whether it's blood type or your vitamin D status, or you could name 15 other things you've probably seen in the last 20 days. You don't, it's probably just a combination of things. You almost have to, in some ways, I don't want to diminish it any, by just saying it's sheer luck sometimes as to what your chances are. You try to mitigate that by doing exactly what you're doing and I'm trying to do, which was to steer clear of people that are obviously symptomatic. But the people out there that are asymptomatic that you run into, how do you
protect yourself?
Yeah. How do you do that?
So do you eat out and do you do all that, or do you go to work and go home?
I have eaten out at a restaurant, socially distanced 3 times since March with my wife, and we went at off hours when there were, table after table separating. We wore masks, and just to see what was it like to go out there to do that. But
And then
otherwise,
did you spend the next 3 days thinking you caught it? Like, oh, I think my throat hurts. Oh, I think I have a headache. Oh, I think.
Yeah,
Did you do
yeah.
that?
Well, we do take out a lot as needed, but yeah, I've had a couple of viral infections that were turned out to be other conditions, a para-influenza and a metapneumovirus, and it feels like you have the same kind of symptoms, but you don't, because I have a sense of smell and all of that, and I don't have the muscle aches. Of course, we are mandated to get the flu shots where I work. We have 10,000 physicians in this system I'm part of in Texas, and so they want everybody to be totally protected against this. And we have ample PPE here, and we have enough ventilators and all the other things you hear talk about. We have here, and so far so good. We've not had a surge yet, but we're ready for it. Our children's hospital could actually take adult patients up to a certain age
if they have to, God forbid.
Yeah, to accommodate the adult hospital across the street, so they could take more patients.
Would you not get the flu vaccine? Are you changing hats? Are we changing hats? Is it a hat change?
I'm gonna change to a wig now. So
all right, what are we wearing now? Oh, it's the 80s. Okay.
It's my Guy Fieri hat.
Oh, Guy Fieri. It's not the 80s. All right, I like it. Yeah, there we go. So wait, I just asked you something and now I forgot what it was. You were talking about, would you not get vaccinated if it was not something that they insisted on for the flu?
I have been, well, as you get older, you think about infectious diseases. I've had Pneumovax, I've had the shingles vaccines, all the current ones, hepatitis. As a healthcare provider, you have to get them anyway.
Yeah.
But I like to hedge my bets. I don't want to get something I can prevent, especially something like pneumonia. Yeah. And so I've done all that. And so we get the flu vaccines. And quite honestly, my infectious disease specialist down the hall from me, he said something the other day, which it caught my ear, which is individuals who get routine flu vaccines are basically in a constant mode of triggering or stimulating their immune system. And he says there is some evidence that helps overall in fighting disease, because your immune system's not totally been put in isolation, and those muscles are in a way
they atrophy.
They don't atrophy. So he said that's a good thing. And of course, we got our flu shots. Everybody in my family's gotten their flu shots. And now we have patients, of course, who are not real fond of vaccines at all. And I don't think those are limited to Texas. I'm sure they're across the country.
No, they're here too.
And so I certainly understand that. I can't compel anybody to do that.
Right.
And it's kind of to me, it's kind of not, I don't make much of a point. It's a pointless argument sometimes to discuss it with people if they've totally chosen not to do this, whatever their personal beliefs are.
You can't talk anybody into anything. You just can't.
I have to respect that. I respect that. Yeah. And we move on and we talk about things that we have in common.
I didn't do it when I was younger, and then I got really sick from the flu once, and now I do it all the time. And my family doesn't do it because my husband's kind of like he's not a non-vaccine person. Like, my kids got all their vaccines, but the flu thing, he's like, I don't really need it. I don't, whatever. But this year, he's 65, he's going to do it, and he's thinking about having the kids do it too, just to protect everybody. Yeah. So we're all going to get it in the next week. Okay, so you're 9, then you start to get control and you go on a pump on your 80 in 1981. What year were you in med school?
I was actually at the end of my first year. I met my endocrinologist. His name's Melvin Prince, Mel Prince. He did a lot of work in San Diego with Eli Lilly later, and then he was in Galveston where I met him. And he's still alive, and he's a wonderful man, awesome doctor. And he got me on the right path, just like Sherm Hovey did with you. Yeah. And he spoke to me as a person, and he saw my reluctance to make change. When I came to medical school, I was on 1 injection per day. Still. And he approached me about multi-dose insulin, which was almost like a totally radical idea. It was a radical idea to somebody who had only done one thing all their lives, and I was resistant to change. And so I finally, after much discussion with him and his diabetes educators, chose to do two shots a day. Well, I realized after that I felt better, that I had more energy. I just felt better physically. And after that, it was an easy sell to do multiple shots. I did 3 shots a day, then went to a pump shortly after that.
And how old were you when you started testing with glucose?
Glucose testing around the same time.
Okay,
because
wow.
That was not something. I did not see a lot of doctors. I saw my pediatrician. I never saw an endocrinologist.
A specialist.
I should have said that earlier. I never saw a pediatric endocrinologist. Not that they didn't exist. There weren't many of them, and they were rather prescriptive. And I'm not sure how much that would have changed things. But I did see an adult endocrinologist who had a lot of empathy and a lot of understanding, and it was extremely patient with me. And I learned a lot from him as a physician, because I've had to emulate a lot of that behavior with some of my own patients who, for one reason or another, are just not ready to accept their diabetes, take ownership, or make change, and just have to keep them going until hopefully that light bulb goes off in their heads.
So that's not the doctor you mentioned, who was your first mentor that you learned from?
Well, the first one I met, well, that was my first personal physician was Mel Prince.
Okay.
And then my pediatrician was a guy named Sam Hunt. He was, he's a general pediatrician in Dallas, Texas. But the other person I learned a tremendous amount from is Dr. Luther Travis. And Luther Travis was a pediatric nephrologist who was one of the fathers of pediatric diabetes in the country, wrote some of the first instructional manuals and books. And at the time, a nephrologist, as you know, is a kidney specialist. They had as a profession had a propensity to see a lot of the kids with diabetes, because they were even starting to develop kidney problems in adolescence. And so Dr. Travis took charge of being over the pediatric diabetes program in Galveston. And so I trained under him, even though I trained with a separate endocrinologist in another part of the department when I was doing my fellowship. And now these things have all been merged. But there was a historical reason behind that. The father of pediatric endocrinology, a guy named Lawson Wilkins, a doctor named Lawson Wilkins, never really had any sort of a desire to manage diabetes in children, and considered it a metabolic disorder, not a true hormonal disorder. Wow. And it's illustrated in a lot of his teachings, and all the people who trained under him in the 40s and 50s focused on non-diabetes related endocrinology topics and professions. And those that gravitated to diabetes oftentimes studied under nephrologists, pediatric nephrologists. And that's how Dr. Travis became my mentor. And Dr. Travis is still alive. He's in his late 80s right now, and I've seen him in the last couple of years, and he's going strong and in his retirement. But I learned so much from him. He operated the children's camp that I now direct, and I eventually took over in 1989.
Oh, I didn't even know about this.
Yes. That's actually what pushed me in the direction where I'm at right now, was attending diabetes camp in 1981. I was in a research study for human insulin in 1980 that Dr. Travis's office was doing. And the nurse that was drawing my blood at the time for one of the samples said, "Oh, Steve, would you be interested in volunteering at this camp we have for children with diabetes?" And I can recall very succinctly saying, yeah, sure, why not? It was with that much conviction. And so
changed your whole life.
The next summer I went to camp. We spent a couple of weeks there in June, and it's like I'd come home. I was around people that had what I had. Yeah. I'd gone to a camp when I was a kid, but it didn't really take the same way this did. Now I was helping people. I was helping them do their urine testing. We were still doing urine testing in 1981 and their injections. But then I met a crew of other people that had lived with this condition who are still my friends to this day.
Yeah.
And then I came back every year, literally since then, and became the medical director in 1989 when Dr. Travis was moving on professionally in the department. And so I've been the director since for 31 years, and I've been attending this would have been the 40 years, but we had to cancel camp this in 2020 because of the pandemic. But we'll have it next year. But it has been so instrumental in my learning. I learned so much, as I mentioned at the beginning of our discussion, from listening to children and teenagers around the campfire, listening to them in the cabins, listening to them at the dinner table about the things that they feel, the experiences they've had, how they've been taught, how they've been treated by peers and by adults. And that's the greatest learning laboratory possible, is to spend your time with your ears open.
Eavesdropping.
At a diabetes camp. Yes.
Yeah.
No, they'd tell to me. I'd sit and listen, and they knew that I wasn't going to judge them.
Right.
That's the important thing.
Yeah. I think a lot of people could learn to listen a lot more, and they would learn, as a hairdresser, I've done a lot of that, which is why I'm doing this, because I've missed it so much. And I feel like so much of the things I've heard standing behind the chair has shaped me into who I am. And so I love to talk to people who pay attention to other people and have learned so much from them. And for you, it took you to exactly where you are, which is like the place that nobody else went to but you, because of your experience and what you learned. I think it's incredible. Okay, so you go to medical school. Did you know right away that you wanted to get involved in diabetic care?
It's the camp that moved me in that
Okay.
direction. I had thought when you first come to medical school back in the era I did, there's always this push to get you interested in family medicine. They get very aggressive about doing this. The family medicine groups do. And so they try to appeal to that. It sounds like what you would have heard with all the TV shows in the 1970s that was all family medicine oriented. And the camp really switched my mind completely. I wanted to be a pediatrician and a diabetes specialist after I went to camp. So that really solidified things. I toyed around with thinking about radiology, believe it or not, but that was just a brief flirtation with another specialty. But I just loved so much that camp and sharing what I had learned personally and finding ways to use that experience in a positive way to support others that are trying to live and grow up with this disease.
And hence the hats and the kitty things in your office that make it sort of a fun, campy place to come when you come see your doctor who has it, gets it, and wants to make you okay with it.
Oh, yeah.
That is a hat change.
Yeah, I got one more hat here I can wear. This is one of my residents gave me this. I got involved with doing resident education back in the 1990s, did that for about 5 years, and then came back. I came back to where I was working then, which is where I'm at now, and I was asked to do it again for another 5 years. So for 10 years, I've trained medical students and residents as well as these other jobs I have. And the residents gave me this because they know I have this affection for hats. The hats come from my childhood. I always had caps and hats and so on. And I started expanding into different, animal hats and motorized hats and, wigs and so on, as you saw earlier.
Yeah.
And then somebody asked me a number of years ago if I was still wearing these hats. This is a young lady who remembered me when she was 10 years old and I was 17. We were playing tennis. We were all tennis players. And she said, "You still wear those hats?" I said, "Well, yeah, I didn't realize I'd worn them that long. But over the years, I take them to camp and I'll have bins of them behind me over here in the office. And I'll wear them. I'll wear a different hat multiple times a day. We'll wear costumes. And I'll be honest with you, Nikki, that's the whole part. You touched on it earlier. When you're a pediatrician, you can let all that stuff go. I have a tutu over here. We have Tutu Tuesdays. We wear on Tuesdays. We wear masks. I tell jokes all the time to the kids, kid jokes to them. It's just, you can be yourself, you can be yourself and there's not all this formality. Now I would get roasted alive if I did that in internal medicine or if I did that in orthopedic surgery. It's just like, you would be totally inappropriate, Dr. Ponder.
But on the other hand, if you were an oncologist, God forbid you had cancer. And people came to you and you made light of it if you could in order to bring joy to the office. Would that suck? Would that be a bad thing?
No. And I think there are a lot of doctors out there, medical providers, not just doctors, but, nurses and other healthcare professionals who take their jobs very seriously, but also can let their hair down and be real people with their patients. And I think, as we all know, laughter and humor are an essential part of medical care, whether it's diabetes, cancer, or you name it. And I think we need to, it helps us bond better with our patients.
Yes.
It helps us better understand each other, and it helps us listen. And I think the biggest challenge we have in medicine right now is time. I say this every time.
Because the insurance companies and all that.
Yeah, well, they want you the desire is for you to see somebody very quickly, snap out a diagnosis or two, prescribe something very quickly, and move on to the next patient.
Yeah.
Never do you really get to know the person that has that condition. You're not given that luxury of having that sort of time.
Right.
And that's still a challenge. It's a big challenge. Even now, I've been able to negotiate a little bit longer visits for my patients when I see them. But from a financial standpoint, if all I cared about was the financial part about being a physician, first of all, I wouldn't be a diabetes specialist.
There you go.
That's the last thing I'd be, right?
Yeah.
But that's not what I got into medicine for.
Right.
I realized that I had this condition. I could share what I've learned, and I've learned so much more over the years from my patients that I never learned in medical school. And so I would never.
But you can't learn in medical school.
Yeah, I wouldn't change a thing about any of this stuff. This is just the best way it could have turned out. Whether it's the camp, whether it's my patients, whether it's the sugar surfing, all that stuff. It's all part of a package, and I have to accept the whole package.
Okay, so let's talk about you and your diabetes. So in the 80s, you start to get control because you had no idea what your numbers were. So when you started to see your numbers and track your numbers, how did that feel when you all of a sudden realized you were 180 most of the day or whatever. Did you know then, had the range come down since when we found out that you could test your glucose? Did they stop saying that under 200 was okay yet? Or
Yeah.
was it?
Yeah, we had, that was when meters came out, that ushered in the era of log booking and charting your blood sugar numbers and doing some sort of mathematical analysis
Right.
of all this information, which even to this day, a lot of our patients don't find time to do or find a strong interest in doing.
They can't figure it out for some reason. I mean, I'm sure it's a little bit of denial in the way, or a lot.
Yeah, or you have the judgment issue, like that number represents something I didn't do
Yes.
well, and it's a negative thing, and so that's one of the second things I tell people following the guilt comment I made earlier, and that is that blood sugars are numbers; they're not moral judgments. And I say that's the second thing I tell people. They're not good or bad. They can be high, they can be low, they can be in range, out of range, but they're not good or bad. I tell parents specifically, I look them in the eye and say, I don't want to hear good or bad in front of a number.
Yeah, how the numbers been? Oh, they've been terrible. Yeah.
I don't want to hear that. It's not, you're not, and think about that if you're 5 years old growing up, hearing that all day long, you internalize that. Even if you're 15, I think you internalize it. But
of course you do.
My point is that you have to hear that at the beginning. And so I bring that up as one of my baseline discussion points. So when they come back in and they start throwing the words around, because it's kind of it's so well rehearsed word to use good and bad. Sometimes it slips out invariably, but I can point it out, say, hey, remember what we talked about? They're just high or low, they're in range or out of range. You have to look at them in an emotionally neutral way.
Can you always do that on your own? Like when let's say that you've had a day, you've eaten, you haven't done your whole pizza challenge, or you've had a whole pizza, you've just eaten what you generally eat, you've taken your insulin, and it's just one of those days where like it's not the same. Do you ever get angry at yourself? And then like, does Dr. Ponder say to Stephen, hey, calm down, there's no judgment? Do you have that moment in your head?
In the earlier days, before I got into more of the dynamic thinking process, yes, I would be a little bit, well, man, what happened here? What am I? Now, I didn't get mad or, scream or yell or anything like that, but it would be frustrating. It'd be more frustrating, I guess, than anything. But when things like that happen now, and I usually know exactly why they happen, and I know the right steps to take to remedy them, and I know that I can remedy them. So the self, and that gets back to the whole purpose of dynamic management.
Right.
It's not about having the best results. It's about developing a sense of confidence in your abilities to manage difficult situations. I can't make bad things not happen to people, but if I teach you how to get through those bad things, if you wouldn't call them bad or difficult periods of time. Yeah, and in sugar surfing, as I tell families, it's all about self-confidence. If you show me a person who's extremely confident in their abilities and can work through and manage problems effectively, I'll show you somebody who knows how to dynamically manage a glucose problem. That's basically part and parcel the same thing.
So true, so true. And it is so helpful to know that if you really do take the time to watch what is right in front of you, you can micro, like you say, carb or bolus. So I've learned so much from the book about that, and hearing you talk about how you do it too. And sometimes you forget to look every 15 minutes. You get carried away with being at work. I'm sure. Do you get distracted at work and not have time to check your numbers?
I do. I've developed a routine. I keep I use my phone and my old style reader, and so the reader is just dangling off my belt on a clip, and so it's hanging down where I just have to push the button and I can look down at my waist and see the number. I can have it on my watch too, but even that takes time.
Yeah, you got to open the watch, you got to find the app, you got to
exactly. I don't
it's
have
funny
to do
that's
so
too much time.
Exactly. So if I'm leaving the office where I'm at right now to walk down the hall, I'll check. I'll do the same thing when I leave the office to come back. So that I have about a few minutes between visits when I'm prepping for the next patient. So I have that. I also adjust the alert limits freely, basically to meet the need of the time. So if I wanted to have mine at 100, like what you said, I've done that before, moved it as high as 100. So I get a very, very early warning of something that, say I was taking a big dose of insulin to bring it down to 250, but I want to find out about it at 100, not at 70 or 80. And I'll do that. Now I'll have to reset it back to another setting. But because, as I say, I'm managing a situation. And part of that situation is how I manage my insulin, how I manage my sensor settings, how often I check, as you say. So I'm not managing a blood sugar or an insulin dose. I'm managing a situation. It involves food, stress. Yeah, well, I just do it. I move from one situation to the next, but that's like life, you know.
Yeah.
I'll manage it through this discussion with you, and I'll do
Right.
it afterwards on the way
Where are
home.
you now?
I'm in my office right now,
No,
and
your blood
so
sugar.
oh, but right now, when I give my talks, I start to drift up a little bit. So I'm as high as 169 right now.
You know, it's
So, but
interesting. I thought I was fine. I'm at 187 right now, and that does not make me happy. I'm a little shamed about that.
well, I think it's adrenaline. When I do
Yeah.
my talks, the sugar surfing workshops I do, I get so rehearsed sometimes that I can go fairly flatline because I'm not doing anything new. But sometimes I get kind of revved up, just like what
Yeah.
you do, and that adrenaline rush tends to push my blood sugar up, and when that's gone, it tends to start to slowly ramp down.
Yeah. And that, if that ramps down and you've taken insulin, that can be a problem. And do you have glucose stuff or something right by you just in case you were talking? And what do you have?
I prefer, I have all sorts of things like juice.
I have these. I have organic gummy bears.
I have that. I have the standard glucose tabs, but yeah, whatever. It's just fuel. I look
Yeah.
at it that way. It's just fuel
Yeah.
to slow things down or boost things up. But and then the insulin, I don't wear a pump, as you know, anymore. I
Right.
just have
Me
a
neither.
pen. And so now I may go back on a pump, and I prescribe pumps all the time for kids. I think they're the greatest thing in the world. I think adults using loops and all that, that's all great too. I don't begrudge anybody about that. Although
Right.
I just finished penning an article, which will come out in about a month or two from now. That's going to be a letter to the editor in AADE in Practice, which is a journal by the Association of Diabetes Educators, about technology burnout or technology de-skilling. And one of your Steve Edelman pretty well, as Steve and Jeremy Pettis, at one of the TCOYD conferences a couple of years ago, they were both talking about when their loops broke down and how they were, they felt kind of at a loss because they'd actually forgotten some of their core skills, self-management skills, which is
Yeah.
kind of interesting to believe because they're both endocrinologists and they still themselves, got kind of so accustomed to having the loop do everything for them. And that made me think that we have kids and adults that are being put on these devices who do so
Early.
much work for them that their cognitive muscles are maybe get a little bit atrophied. So
Or don't even develop if it starts too early.
or if you just put them on it to begin,
That's right.
and then you become dependent upon a technology for your health that you've never known the alternative, the old school alternative. So my point of my column is we need to be mindful of that as educators, and maybe it's not a bad idea from time to time to take a break from high tech management and do things old school. Now I will draw a line at that and say that it's great to have the CGM data. The
Yeah.
CGM data,
Yeah,
I'm not
yeah,
sure
yeah.
I'd take a break from that. I think that
But
would
the
be
MDIs versus the pump, because you
Yes.
need to know how many units to take on your own and all that stuff and count your
Well,
carbs.
and at a conference, at a call we had the other day, as people with diabetes, Earl Hirsch was on the call with us, and Earl says he's back on MDI right now because of he says doesn't have a lot of sites left anymore for
the
his
pump.
pump. And so you have to give your body a bit of a break. And so I think it never hurts every now and then to go back to do things old school.
I've
And then
never been on a pump.
Oh, really? Okay.
And when I was pregnant with twins, my doctor kept saying, if I say pump, there's no discussion about it. I mean pump. And honestly, I think I might just be too vain for the pump. And I was too vain for the CGM for a while. And finally, after much like you, the middle of the night lows where my husband had to save me a few times, we went to the doctor, and Rosemary was the lady who met me there with the Dexcom. And I remember she put it on, and oh my God, Dr. Ponder, I broke down. And I said to my husband, I looked at him and I was like, do you think this is sexy? And he said to me, you know what's not sexy, Nikki? Waking up in the middle of the night with you having convulsions and then me sending you to the hospital and wondering whether you're going to live or die. So if you ask me if this is sexy, hell yeah, it's sexy. Thank you for wearing it.
Yeah. Yeah.
So
you do what you have to do. You
Yeah.
do what you have to do.
I am very much over it. And I remember being in Hawaii and taking off my wrap for the first time and wearing it. I mean, how stupid is that? But I remember being that uncomfortable with it. And then I remember people asking me what it was and being fascinated. And then and I like to talk to people, obviously. So I just got to tell people what it was. And speaking of that, walking down the beach one day, some guy talks to me and shows me his CGM. We start to talk. And this was like 5 years ago. I think we were I don't know where we were. And he worked at a hotel. And he had the InPen. Do you know much about the InPen?
Yeah, I used an InPen for a few months to try it out.
And do you like it? I've never used it.
Oh, it was nice. It's a nice communication tool to your phone, and tracks all your data, your shots, and it's a good thing. I have patients that use it and enjoy it.
Is there any reason for someone like me who thinks about it 24/7 and looks at my watch and looks at my phone and does the microcarbon to change to an InPen from just my MDIs?
I think it would make one of the steps in tracking your dosing a little bit easier. I put all my dose. I have to stop and put them into the logbook.
I never do that.
I do that, but because I use that information for decisions, and I can visually see them on the dashboard that way. Yeah. I can say it's been this long since the dose. Okay, it's time for me to expect something to happen, like a bend or whatever we look for. But the InPen will track when you gave your dose and how much you gave, so it does that automatically for you.
Well, with all that you do in your logging, how often do you blow it? How often do you miscalculate personally?
Well, it's like I use this example in my workshops. If I hit everything just right, the trend lines will move the way I want them to move. Right. If they move too far, that's what I have fast-acting carbohydrates for. If they don't go up enough, that's why I can always consider taking another dose of insulin. So I always explain that an automobile has an accelerator and a brake, and they're both there for a reason. Yeah. And that we just don't take our foot off the accelerator and expect the car to come to immediate stop unless we're at Disney World or something like that. But that's the way it is, and that there's no shame in stopping a drop any more than it is to try to curtail a rapidly rising
Interesting.
high.
Because you went right to the lack of shame thing where I'm like, how often do you blow it? Well, it's not about blowing it. It's about maybe I gave it too much gas. I'm just going to give it a little bit of break now. And that is such a better way. I mean, like, I'm well-versed in your way and well-versed in my natural way of thinking that, I'm not going to beat myself. I'm not going to do that. But of course I'm human. So it happens. And it's interesting to have the conversation with you who is so not about that and so on top of it because of having it, how you practice it and what you teach, which I don't have all of that. I just have having it and what I practice. And if I could have you in my head all day long being Nikki, put the brakes on, Nikki, give a little gas. Don't feel bad about this. Like I'm sitting here now thinking, I can't believe I'm 187. I can't believe I'm 187. But like you said, I would imagine that if I let's say I gave myself insulin now, I would probably crash in 2 hours because when I'm done with the adrenaline, I'll probably come down.
Or if you did correct it, you correct a portion of it, like you have a third or a fourth. I have a couple of friends, great examples. I use them. A woman who was in the underground in London, a fight broke out right next to her, and she's a very well-known person with diabetes, Liz Warren in London. She sent me an image of her trend line, which went up and then immediately came down as soon as this altercation stopped. I have a partner who also has diabetes. He had a stressful encounter with a patient. His blood sugar went up, but his also came down without any significant correction. Interestingly enough, mine generally requires some sort of push to bring them down. If I go up because of that, I need something to bring them down. That may be because my basal is set very, very low. Okay. And it's just something I call being basal neutral. I like my basal to be completely just level, so where it doesn't drop me when I'm not doing anything, or it doesn't make my blood sugar go up excessively when I'm not eating food or doing anything. And so
what do you take for your basal?
Well, it's interesting. I take 11 units of Tresiba, which is degludec insulin. And I did that based on a series of just reductions. I'd make small reductions, and then I'd go for periods of time without eating just to see how long I could go. And if it wasn't working, I'd just tend to go up. I just start to trend up. Right. If it was too strong, between meals, I just tend to drop all the time. I think most people, and this is not me saying this, but other people agree with this, most people run rather basal heavy. And basal heavy, especially in kids, allows you to nibble and snack between meals and have a little extra food. But if you're truly basal neutral, what's happening is you're trying to match the amount of glucose entering your bloodstream with the amount of glucose that's exiting your bloodstream, keeping in mind that the sources of glucose entering are not necessarily food. Those are internally generated through this adrenaline that you and I are doing right now with this talk, but that will go away. So, and I don't talk about this in the book, and I think we've got to a point in discussion, this will make a lot of sense now. I am not managing sugars as much as I'm managing glucose disposal rates. I'm managing the rate of disappearance of glucose or the rate of entry of glucose into my bloodstream. If I had two faucets and I could juggle those as to what's going in and out of the system, I'm trying to do that through physical activity, through food, through insulin action, and my understanding of them conceptually. And that's what I'm doing. And I'm trying.
So on the days that you were eating less just to manage where your basals were, if it was going up, would you walk on the treadmill for 10 minutes to bring it back down just to see what that did too?
Yes, I would do that. I could also, it's also when I learned how to microbolus, I'd be on a steady trend line. I'd take 1 unit of insulin
See
or a
what
half
happens.
unit and then wait an hour or so. And I did that. Those are experiments. That's part of what I wrote in the book. And you kind of figure out what your body's systems are designed to work around. And you start with those. Now, just as you said before, that doesn't mean it's going to happen every time that way, but it gives you a starting point. So that's my baseline. I can use as little as half a unit of insulin in the absence of any, recent food or stress. And that will move me, believe it or not. Yet I take 11 units of Tracebo, which I have kids that take 4 times that much.
So you never change your long acting? Like you don't have to change it depending on where, I mean, like I'm a woman, so I don't know if you noticed that. I'm a girl. Yeah. And so while I am 54 years old, I don't think I've started menopause yet, but that's just because I'm on the birth control pill. So it doesn't make any sense at all. Mm-hmm. But like hormonally, towards the week that my period would come, I need more insulin. Right. And then somewhere in there, just like one of your, prepubescent or pubescent girls, somewhere towards day 4, day 5, all of a sudden it's too much insulin. Like I've got to change my basal all the time. Do you not have to do that as a man?
No, I don't do that as much. I do more microbolusing and microcarbing, as you already touched on earlier. That's what I do. Now, to your point, anybody you've interviewed or will interview that's on a loop or on any sort of partial closed loop system records the delivery of that insulin over a 24-hour period. And I have a couple of my patients who let me eavesdrop on their systems. And if you look at their insulin delivery rates, when they go up, when they go down, it's like a barcode that every day is different, just like what I said in the book. And these people are living normal lives, but their blood sugars their insulin doses are surging in some cases based on what the device thinks they need. And they're going down to nothing when it thinks they don't need anything. So there's this constant ebb and flow of insulin production. And if you look for any consistency in it, you don't really see a whole lot of it, aside from maybe the meals. But that's the way biology is. That's the way people are. As I may have written this in the book, I think I wrote this one in the book, that the average person without diabetes produces about 11 waves of insulin every day. And then you have to remember, a wave of insulin is then counteracted by waves of counter insulin forces, a variety of different hormones and so on. And of course, part of the insulin is those insulin waves are necessary to metabolize 2 to 3 meals a day, of course, and get you through the night. So, and that's why human blood sugars do kind of go back and forth like that, and not a straight line. They're moving up and down because we're biological systems that have to maintain a range. We have to stay within a certain lower and upper range most of the time. Yet we can push the extremes. We can take a healthy person and push them over 200. We can take a healthy person and push them under 60 if we do the right things to them. But under normal circumstances, most people without diabetes will stay somewhere
in a
between
range.
65 to 200 roughly. Usually
they do go to 200.
Well,
somebody without diabetes.
The agreed upon upper limit is 200 from a diagnostic standpoint. Anything over 200 would be considered, and randomly to be abnormal. But that's just a committee decision. There's nothing magical about 200. It's just that we agree that 200 would be kind of high.
So you were talking about. So I read somewhere years ago that typical people without diabetes, obviously typical is what I mean, make around 20 units a day. Is there any truth in that? Or does that depend on how much you weigh and how much activity you do and all that? Is there any truth in that?
From an insulin requirement standpoint, and this is talking about injected insulin, it's about 1 unit per kilogram of body weight per day. So if you're a 50 kilogram person, if you're an adolescent, the round figure was 1.2 units per kilogram.
Let's talk pounds, since I don't even know what kilograms are in weight.
That's easier. I memorized it as a kilogram thing. It's 2.2 pounds per kilogram.
Okay, so you're talking about a 100-pound kid.
Yeah.
Or 120.
So about 40 units, 45 units for a 100-pound kid.
Okay, so it's not right, the one that I did. Yeah. The one that I heard.
Well, that's just from an injected insulin standpoint.
Okay.
Remember, the injected insulin you take gets broken down before it ever reaches its target because you're taking from the outside in.
Right.
You're talking about insulin made from the inside out.
Yes.
The amounts you make internally are far smaller.
Okay, so I might be sort of closer to right.
You may be. I mean, it's just.
But there's no real number that we know for sure.
Right. And people's sensitivity to insulin changes and shifts all the time. Even throughout the day, your insulin sensitivity is also adjusting and changing.
Right, right, right. I also heard you say something the other day in one of your talks about being 64, so the dawn effect doesn't affect you anymore. Do we outgrow that?
A lot of the dawn effect is secondary to growth hormone secretion, and many individuals that are over 60 tend to make less and less growth hormone at night. So you would expect that to play less of a role in those morning rises in blood sugars that you see. And so, yeah, that's where the origin of that statement comes from.
I had never heard that before, and I guess I should start to know these things as I get older.
Well, I always caveat everything by saying that that's just a concept, and that's in general. And you can find 5 people that will break that rule out there.
Absolutely.
But if 95% of them do it, then you can use that as some sort of guide in your decision making about what you'll do next.
Yeah. Okay, so I just want to make sure I didn't leave anything out because I wrote a bunch of questions down. I wasn't paying attention because I just wanted to talk to you about it instead of like interviewing you. But okay, here's a silly question. How much of the time are you in your range?
Well, I get my weekly reports. So my time in range for this last week was 96%.
Beautiful. And your range is set at?
Mine's 70 to 180, the standard
Beautiful.
time in range.
Okay.
If I set it tighter, then I get down into the mid to high 80s.
Yeah.
So for the reasons you described earlier, sometimes I'm doing other things and I'm not constantly dwelling on my sensor. But
Yeah.
I do glance at it probably upwards of 20 to 30 times a day, just briefly. When I'm driving, when I'm walking or doing anything, I look at it. I use it to manage situations, like I said.
I am constantly looking at it. And I remember when I first got it and Mitch said to me, how much time are you spending looking at your phone and for your numbers? And I was like, all day long. And he said, why? And I said, because to tell you the truth, Mitch, since I got it, part of my DNA wakes me up in the morning to go to war with my diabetes and kick its ass. And I know that I can't kick its ass all day long, but if I kick it more often than I don't, I feel like I've got control. And that makes me feel strong. It even makes me feel smart. I don't know why, but it just does.
Confident.
Yeah. And I don't think that people who don't do what I do aren't smart, but I know that I have to do it that way because it makes me feel better every day if I have it more under control than less. And so my numbers are, I never change them. They're 120 and 80. And so when I look at the thing and it says that I'm in range, and even when my doctor looks at it, he's like, you've had too many lows. And I say to him, yeah, but remember, my low is set at 80. The sensor says I'm low, but I'm not. So it takes that 15-minute lag time to catch back up. And
let me give you a tip. If you're using a clarity report to do this, just go into the settings and change the range to be 70 to 180 across the day. It'll go back to reset at whatever it was before. Then you print out your report. It'll have your time and range up in the corner. I'd have to do that for my kids. Well, so you'll see the time and range because I use the International Standard Commission's definition of time and range, which is 70 to 180. I don't aim for 180, but I use that as my number. And so when I see kids and they'll be coming in with devices that are set at sometimes really, really tight ranges, I want to make sure I'm comparing apples to apples. And so I will go in. The first thing I do is set the lower range at 70 for 24 hours and the upper range at 180 for 24 hours, then print out their forms. And then you can see the time and range. You can see their standard deviation, their average blood sugar, whatever. And
it'll make him more comfortable.
Yeah. Well, in your case, it may help you with your physician a little bit, give you
that's a good idea.
Up with.
So you don't beep.
I want to ask you one other question.
What's that?
I want to ask you one other question, and that is, before I look at my sensor, I always think, what direction might I be going? And it's a tri-directional feeling. It's either a period of steadiness, or do I feel like I'm slowly drifting or dropping, or do I feel I'm going up in some fashion? I don't need to be any more than 3 directions, straight across, down, or up. And I realized over months of practicing this that I got very, very adept at being accurate when I looked at this, even with very subtle changes. Have you found that to be the case with yourself?
I don't feel I'm always surprised when I'm over 120. I'm always surprised. But I definitely, when I'm doing stuff and I think, I feel like I'm dropping, and I'll see that I'm 90. And then sometimes, and almost 80% of the time. It'll say I'm 90 and I'll be like, huh, and the line it's drifting, but it's not dropping, but I can feel like something's happening. And then inevitably when I feel like that, my next reading is that loud beeping and I'm 72. So yes, I do feel the drops for sure. I don't necessarily feel the rises.
There's a part of your brain, there's a part of your core brain, your reptile brain, if I use that term, that senses.
Wait, are you calling me old? Like a dinosaur?
No. That's this part. We all have this, but it's that feeling. It's a feeling of, oh crap. It's that oh crap feeling, and that's what's being activated by glucose shifts. In fact, that's been written about in the medical literature. Your brain can sense these subtle shifts, and it's in part of your midbrain, and it sends out a signal to your head of kind of a uneasiness. I have a bad feeling about this sort of thing, and you may notice that you're a very uplifting person to talk to, obviously. But if you have a little voice in the back of your head that's saying, "Oh, I'm not very happy. There's something not right here," that could be what's talking to you. That's the inner voice that's saying you may be drifting down. And if I'm going steady, I have this chilled out, just, hey, things are really, I'm rocking here. And if I'm going up, I have this I have a more a physical feeling of an easy, it's more in my body than it is in my mind. And so that's how I best characterize those things. And when I talk to groups about this, I'll get a lot of heads that nod up and down and say, yeah, I know where you're coming from. I call it something different, but I do have that sense of uneasiness. It's a sense of uneasiness, mental uneasiness, or I start worrying about something I wouldn't normally worry about in my head. And I say, I must be kind of drifting down a little bit because I don't feel real chill right now. And I look down and sure enough, I'm drifting down a little bit. So.
Yep. It's interesting because when I looked at my number and I saw that I was 187, I guess I do get a feeling in my stomach when I get high. So yeah, if I tried to identify with that more, which I'm obviously going to after this conversation, I will email you when I get a hold of that. Okay, so what is your very worst low story?
Oh, I've had several of those well before the sensors came in. Yeah, probably the most interesting one was in 1983 at diabetes camp. We were in a very rural camp in Central Texas, and during the middle of the night, a very early version insulin pump administered 53 units of insulin to me inadvertently, just a pump, a runaway pump is what they used to call them.
Oh my God.
And then I fortunately had a roommate who was an endocrinology fellow at the time, and he saw me having
a seizure,
having a seizure, and got me to the infirmary and got treated, got IV dextrose and so on. And then I looked at the pump later and I saw an error code, and these error codes had to be reported to the Food and Drug Administration. Again, this is 1983.
Right.
And we never knew what it was, but it was a pump error, and they didn't have any of the checks and balances pumps have now on them. But that was a pretty dramatic low, and it was in a place that you would otherwise not have expected to have had the help I had. And
yeah, you wouldn't have survived at a regular sleepaway camp.
Well, yeah, with an endocrinology fellow, and he happened to have all the stuff he needed. He recognized what was going on. He knew who I was. So I had everything going in my favor, aside from being in a rural, remote area.
Yeah.
And but that was my closest call. But I've had issues. One time I got a low in the car and going very slow, and I ran into the back of another car 35 years ago, before sensors, and the policeman who came to call on me, check on me. It's interesting. I didn't get a ticket for that because he happened to have diabetes, and
That's the only reason you didn't lose your license.
I didn't lose my license, and I ran into the back of a parked car. I didn't hit anything, and there was nobody else in my car. But it was those are things that those are personal stories, and I've had lows during the night like you described that you've had before. Those are very disturbing when they happened.
Oh, when you wake up in the hospital, it is so sad, and you have no memory of any of it. You just can't put it all together, and it's like a real life Twilight Zone.
It's what sensors have meant the difference in night and day. That's because right. At one point before the sensors came out, I thought that was going to be the rest of my life. It'll be having these unexpected lows that'll get me when I'm in the sleep, and something bad would happen. Wouldn't be in the right place, wouldn't have the help I needed. And I've just been lucky up until now. And to me, that's why I think sensors are such a lifesaver, regardless whether you're connecting them to a pump or not. It's just having that awareness.
Agreed. I got to tell you, I can't believe I lived as long as I did without it. When I think about, I tested a lot. I tested 30 times a day always. Just because I wanted to know. I was that curious and I wanted that kind of control. Clearly, I'm a bit of a control freak. You should see me put mascara on in the morning. That's a whole nother crazy thing. But like I have control issues, and it actually works really well if you're a diabetic for me. I'm not sure my kids would agree with it, but I don't think I do it to them. But still, I checked 30 times a day. I once was driving home on Sepulveda, which is a very big thoroughfare in the city. And I was waiting on table. So it was past midnight. So there's nobody there, thank God. I apparently was being silly on the way to the car when a gentleman was walking me to the car. I climbed in through the passenger seat and over my stick shift. And I passed out driving, woke up at UCLA, and I had hit a telephone pole, rolled my car 3 times. Nothing happened to me, thank God. Yeah. But they said I was 13 when they found me. Now, I'm not sure that's true, but because I remember getting out of the car, 2 boys pulled me out of the car and they were like, "Are you drunk?" And I'm like, "I'm not drunk, I'm diabetic." And I probably wasn't carrying anything with me at that time at night or whatever. So I remember I used to live in an apartment building where there was a bunch of girls living, and on the top floor, they were all girls. I woke up in the middle of the night, I knocked on everybody's door. I was naked as a jaybird and I was doing ballet in the hallway. And now I am no ballerina. And then I went back in my room, in my house. It was like a dorm, really. They were like just a bunch of girls' apartments. Right. And I remember I had to pee, and I woke up in the morning and I thought, I think I peed in my vegetable drawer.
Oh.
I totally peed in my vegetable drawer. Blood sugar. So I've had some silly stories, but I can't believe I just said that, and I'm going to let people see this, but
it makes you do some strange things. Low blood sugar. Yeah. Yeah, I read once that anything is possible when somebody has a low blood sugar. You can't characterize them, the responses somebody has in one simple statement. No, anything is possible.
There's been so many things that I didn't say that would be even more embarrassing, but I can't believe I lived that long and just didn't die by mistake in the middle of the night when I lived alone. And the idea that my friends who say, they're like, "Oh my God, doesn't the noise of that thing bother you when it goes off at 80 and 120? And at work, they'd be like, "Nikki, fix your sugar." But it doesn't drive me crazy because much like you, I get to save myself. Right. And I'm so grateful for the thing. And gotta remember the 5, the Dexcom 5 with that big syringe that reminds me of your from 1950 syringe. For the first few weeks, I cried every time I had to do that thing. I was terrified. But when the 6 came out, it's so easy.
Yeah.
It's amazing how easy they've made this thing. I can't even wait for the 7, but the ease and just how much it's changed in the 36 years I've had it. And I swear, if I had your job and I met a little girl who was scared, I would just be like, "Let me tell you something. I have lived through some scary times. This is going to be so easy for you." As long as you I mean, do kids ever look at you and say, "How are you so happy with this?" And do you ever just say, "You can be too, look at me"?
Yeah, I say that. I say things like that. I've been fortunate. I understand where they're coming from. I tell them like I said, they're individuals. They're unique. They have their own life stories. And it's not just the diabetes they have to deal with in life. It's school, it's other kids, and so on. But again, mental health is so important to me when I see kids and making sure they're well adjusted for their lives and they can live with this disease and not let it dominate them. And I'll tell people this. I'll kind of wrap with this one. I'll explain to people that there are 3 places you can put your diabetes. You could either put it in front of you as a barrier that, "Oh, I'm diabetic. I can't do this because I have this thing that keeps me from doing what I want to do." Or you can put it behind you, relatively speaking, metaphorically speaking. "Oh, what diabetes? I don't have diabetes. It doesn't exist." Or you can do, which is what I try to strive for, is it's at your side. It's like a well-trained, well-heeled pet that's at my side. Now, I can't make the pet go away. I have to learn to live with it. But as long as it does what I ask it to do with little feedback or negative feedback, then I'm okay. I can live with that. But I'm not going to put it in front of me. And I think we all tend to kind of vacillate back and forth between all those positions. There are times we just wish it'd go away. We like to ignore it and just pretend it in there. And there are other days we use it we use it quite frankly as an excuse. We could go into a whole nother, podcast about excuses and diabetes, and then we do. We're just human. But more than not, we like to keep it at our side as a trained, well-trained, well-heeled, a minion, if you want to use it that way. Use that term.
I'm thinking a pet, like a pet that you love. Just love it and take care of it.
Exactly.
Okay, then I want to wrap on. I was going to add one more question for you. Mm-hmm. What's the best thing about being a diabetic?
The best thing for me being diabetic is the life it's given me. I have no regrets about this life that I've had with diabetes. There's nothing I would really do different than that's happened to me, because my life is a summation of 35,000 choices a day times 55 years. And so that's millions upon millions of choices. And I don't think there are too many choices I go back and say, no, this major life choice I wouldn't do. I've been very happy with the choices I made. I'm very happy with my life right now. I'm happy where I'm at in the world. And I happen to have diabetes. And it's actually been a net positive, if you want to look at it that way, for me in that regard. That's how I look at it.
I would agree with you. And I always say, when people say to me, you seem so happy about it. And I'm always like, I don't think I'd be half the person I was if I didn't have it. I clearly don't know who I'd be if I didn't have it. But I do know that because at 18, I realized I could die. I became serious about my life. I took care of myself. And at 54 years old, I've been taking care of myself for 36 years. And it has taught me to be empathetic and compassionate to other people. I raised children who very early on knew that they didn't always come first. Sometimes it was stop, drop, roll, and take care of mom. Mm-hmm. And I have 2 children who are incredibly compassionate and empathetic with whatever's going on with other people. And I mean, I'm kind of grateful. Like, it's something I can manage. I do it well. And somehow it even impresses people that I do that well. And that's kind of a nice thing too,
yeah, it is.
you know? And so it is so nice to talk to somebody who doesn't hate being diabetic, and everything you write and everything you talk about, and even your hats just indicate that we're okay. And what you said about like having it walk beside you is my new thing. Like I think of it as much as I love my little doggy, like it's just another pet that I love and I take care of. And as long as I take care of it, it's really good to me.
I respect the right of people to not be happy with their diabetes. I certainly do. I'm not here to tell people how to feel. Right. All I can do is try to be an example like you, or a wonderful example of this approach to life. I think you are fundamentally a happy person to begin with, and this did not diminish that. And in some ways it enhanced it. And I think the same thing in some ways applies to me as well. A wise doctor once said that the best way to live a long life is to develop a chronic disease and take good care of it. And I do think that's evident here with both you and me and how we're approaching life with type 1 diabetes.
Cheers to that, my friend. What a pleasure this has been.
Likewise.
I am so grateful. And I hope that at some point I will reach out to you and see if you want to do it again with whatever you come up with. And if you just want to share it with me and I can share it with others, I would be so incredibly grateful. Just grateful.
I will get new hats, and I will have a fresh change of hats. And actually, just for the audience, as we were talking, I did take a small correction dose while we were on air.
So where are you now?
Well, I'm going up. I'm starting to turn. I went up to 187 from that 169, and now I'm starting to pivot. And so that was about 30 minutes ago when I did that. So this is the timing. I knew this would happen, and it'll start to come on back down.
And I wish I didn't put my insulin here, because I was like, oh, I just took some, I'm fine. I was going to do that, but I didn't want to get up. And anybody who's wondering if he wears hats because he doesn't have a full head of hair, yes, he does. Full head of hair right there. This was charming. I am so grateful. Thank you from the bottom of my heart. And I hope you guys all enjoy this. And I'm going to make sure that we can do this again. So I will look forward to that.
My pleasure. Thank you very much, Nikki.
Thank you so much.
Have a great day.